I like to refresh some notions presented during the first and during this webinar. The reason is to encourage all participants to question and share their own perspectives. Knowledge about the impact of alcohol on adults has been learned over several centuries. In contrast, knowledge of the impact of alcohol on the embryo, fetus, and on growing children is very limited. Nonetheless, it is well known that alcohol is a narcotic and a teratogen, that is, a cause of alteration of embryonal fetal development. Listeners know that alcohol is legally sold even in food markets, but this fact is worth to be stressed because it reflects the tolerance or indifference of society toward the health risks to the unborn and future generations. Another nuance is that the acute alcohol consumption may become chronic. As illustrated here, acute and chronic alcohol consumption lead to distinct social pathologies. Here we focus mostly on alcohol abuse by the young. The young or minors of age should not consume alcohol, but they do, and in growing numbers. Such episodes can and probably do damage their developing brains. Of particular and tragic consequence of circulating alcohol in pregnant women is its destructive impact on developing tissues in general and on brain cells in particular. So I believe it's worth repeating. We know quite a lot about the sociopathy associated with alcoholism, and we know much too little of the sociopathy associated with alcohol consumption by the young and the impacts on the embryo. The World Health Organization underscores that there are 44 million Ukrainians, or half of them, 22 million, are Ukrainian women. The data also shows that 7% of women between the ages of 15 and 19 engage in heavy episodic drinking. This implies that every year there are 62,000 teenage pregnancies who participate in heavy drinking. Among these 62,000 are included some who obviously are already pregnant and they hardly know it. These pregnant drinking immature teenagers are quite likely to deliver damaged infants. The question, how many? The answer, many. Then there is the perspective of the infant. It is well known that only 1 in 10 or 1 in 20 of them have visually detectable signs of alcohol teratogenesis. The rest look normal, but have behavioral and intellectual deficits. Now let's talk a little bit about diagnosis process. We hear a lot about experts, the results of their research, which by implication implies they have many resources and time. That's not the same as in the case of the standard medical care. Those circumstances imply that most of the pediatricians, neonatologists, psychologists, psychiatrists, neurologists are not trained to recognize alcohol impacts, nor do they have consequently any experience. The consequence is obvious. Most of the instances of alcohol damage are either recognized quite late or never. And even the experts have difficulty diagnosing alcohol damage. The clinicians have an extremely vast differential diagnosis. The causes of growth and developmental delays are many. The same is true for the specialists in psychology, psychiatry, neurology. They have a vast differential diagnosis as well. Causes of developmental delay, intellectual deficits are many. The criteria to diagnose fetal alcohol syndrome or FAS are quite strict. Dr. Jones and I stressed three main domains for such signs. Those in the area of growth deficiency, those in the area of dysmorphisms, major or minor malformations, if you like, or aphases, that is a characteristic face with unusual proportions, and short stature, low weight, and in particular small head or microcephaly, all of them combined with neurobehavioral deficiencies. The diagnosis of ARND or alcohol neurodevelopmental disorder concerns children with such anomalies but without dysmorphic signs. In other words, physically they look normal. The FASD category concerns children with neurodevelopmental disorders and only a few fetal alcohol syndrome signs. That is insufficient for such a diagnosis, but suggestive. As noted several times before, there are nearly 20 times as many instances of ARND than FAS. Why are the FASD diagnostic criteria so strict? Only 1 in 20 alcohol-impacted infants are so diagnosed. This is because of research efforts seeking agents that can block the toxic or teratogenic impacts of alcohol, or alternatively, to promote the regeneration or repair of damaged tissues. Likewise, the ARND diagnosis is also strictly defined because of research demands. That is, because of the need to find optimal modes of promoting the development of damaged channel or alternative channels. However, from the perspective of standard medical practice, there is an increasing consensus to adopt the FASD label for all degrees of alcohol-induced anomalies thus far included in the FASD, FAS, and ARND categories. Note that the word alcohol is embedded in the labels fetal alcohol syndrome, fetal alcohol spectrum disorders, and alcohol-related neurodevelopmental disorders. Why? Because the diagnostic criteria require proof that there was alcohol consumption by the mother while pregnant. This indicates that, in a sense, FAS, FASD, ARND are not true diagnoses unless they manage to borrow, if you like, an element of evidence solely provided by the mother of an infant under study. And this then opens a dilemma concerning difficult matters that I will allude to very briefly next. Consider that the diagnosis of FASD stands on the fact that a mother must confess to have consumed alcohol during the pregnancy. Consider that such poses an immediate possibility of the mother being stigmatized, and likewise that her infant may be stigmatized. And what do we have to offer that is beneficial from the mother going along and providing such an admission. Obviously, many will not. I almost regret to say that there is an imperative to add the red circle to this graph. Many state institutions and programs for the care of orphans deserve a stigma of opprobrium. I personally think that former USSR authorities and those of its satellites are particularly stigmatized for their inhumane treatment of abandoned infants, many of whom were considered to represent fetal alcohol syndromes, often wrongly. In the interest of brevity, I will not dwell on this subject, but must stress that Ukraine is included among those who deserve opprobrium. And even today, this is a source of national shame. Regarding adoptive parents, knowing that their adopted infant is an instance of FASD may be welcomed by them, but that is not the point either. What matters is not what benefits the adoptive parents. What matters is what benefits the infant, the victim of a fate that it doesn't deserve. Such reality, in my view, is one of the strongest arguments that unless efforts to establish diagnosis are inherently linked with programs of early recognition and programs of comprehensive care and prevention, resolution of the negative impacts of alcohol on future generations will be modest. I invite the panelists and participants to engage in a vigorous discussion, to present questions and suggestions, all of which are essential to frame solutions. Thank you.